All right, thank you for inviting. Basically, this would be a sort of less formal talk, but it will specifically address the iliac and popliteal aneurysms and what to do with them in practice. So, the more interesting question is they are different not only because they are, one is an iliac artery, another one popliteal artery, is that they're completely different, one of being central aneurysm, another one being peripheral aneurysm. They behave completely differently. Just like in this famous story of Dr. Jekyll and Mr. Hyde, they are completely changing once they're crossing the inguinal ligament. Their nature changes. And so let's briefly talk about iliac aneurysms. You already heard a lot about aneurysms in general, and it applies, pretty much all of that applies to iliac aneurysms. They behave the same, they have the same indications pretty much. I mean, usually we go by size of approximately 3.5 to 4 centimeters to prevent rupture, because no ruptures have been described less than 3.5. And repair are basically the same, either open but more commonly endografts. The only caveat here is that there's two ways you can treat iliac artery aneurysms. One of them, you can preserve the hypogastric artery. Another one, you have to sacrifice it. And this is a quick schematic of what it means. So you put an endograft, there's an aneurysm here, but ignore that. There's a bilateral iliac aneurysms. On one side, the graft is extended into external to provide the flow to the leg, and the coil shuts down the hypogastric artery. On another side, the hypogastric artery is preserved by putting a graft that just has a separate flow to it. And those two grafts, they're just sitting there nicely together, side by side. So you preserve the flow to pelvic organs. And the way it's done is basically, this is done with the endologics graft. No other graft can actually do that because the bifurcation is preserved. But the bottom line is that you go from one side into the hypogastric, another one in the external, and you deploy them at the same time. It's actually quite quick and quite easy to do. And in the end, you can see a picture like that where the aneurysm is excluded and bilateral iliac artery aneurysm excluded, and both hypogastric arteries are preserved. So what happens if it actually is occluded, which most of the times people do shut them down. So if that happens, about 30–40% of people would have buttocks claudication, but that usually goes away. And very rarely there are other problems. The interesting thing is hypogastric arteries are not really cross-talking too much. So if you have occlusion of one of them, you can sacrifice the other. Usually people give a couple of weeks, but most of the flow in the hypogastric arteries is actually from the thigh arteries, from the profunda femoris. So you can occlude both, and people usually do fine with that. And now we'll cross the inguinal ligament and go to peripheral aneurysms. And popliteal aneurysm is a good example because it's the most common peripheral aneurysm. And so it's easier to basically address all the issues that has to do with peripheral aneurysms and their behavior. So it's found in 14% of patients with aneurysm with a AAA. More interestingly, the opposite is a lot more exciting, is that about 60% of people with a popliteal aneurysm have abdominal iliac aneurysm. Now, abdominal iliac aneurysm is very hard to find on physical exam on our obese people. Popliteal aneurysm is possible to find. So if you find a popliteal aneurysm, that would be an indication to send for aortic screening. In fact, most people, when they feel popliteal artery pulse, they think that's an aneurysm because they usually can't feel it. So there's something to practice. Peripheral aneurysms, they rarely rupture, but they must be repaired regardless of the size. And for popliteal aneurysm, usually 2 centimeters is a cutoff. Unless they have thrombus, then it's at any size. And so when they do present problems, then they would present with either thrombosis or embolization. And it's a high number of people who would develop that. Only 5% of them would rupture, and usually people don't die from that, although the limb loss is 50%. So the difference between repairing and non-repairing is that the limb loss, if you don't repair, is up to 40%. If it's treated electively, it's less than 1%. So there's a vast difference between the two. What's another very sinister side of the popliteal aneurysms is that the claudication is caused by the repeat embolization is unreconstructible. This is one weakness that we as vascular surgeons have. We cannot fix loss of runoff. We have a loss of runoff, there is nothing we can do. So, but there is vascular surgeon who can, fearless surgeon who can take care of either the popliteal or iliac aneurysm. So the popliteal aneurysm is repaired openly, traditionally, and still probably most of them done open. And the aneurysm is excluded either by putting a usually vein, because veins behave the best. You can exclude the aneurysm, you can just bypass around the aneurysm. So several ways to restore the flow. The key thing is to get it out of circulation. This is the case that Dr. Gagne just did last week. He sent me the picture. So there's a small aneurysm with a clot in it, ready to embolize, to shut down the runoff. And he took care of it, and the patient is very happy. So this is another way of doing it, is doing it with endovascular approach. And the way it's done is basically we put an endograft that seals off the aneurysm. Now this one, you know, the type 2 endoleaks or whatnot are not as relevant, because all we need is to exclude the clot from the lumen. They behave well, but look at this. So this is a bent knee. See how it bends? And the more you bend the knee, this is barely bent, right? If you bend a little more, it can completely, basically be folded in half. And that's when usually they shut down. So the endografts have one caveat, that they really usually should be done in people who are not that active. Because if people will be squatting for 45 minutes, doing something, gardening, they might present with occlusion of the popliteal stent. So here's an interesting question. Which is better? So it's a little loaded. Which picture is better? Here's where we have a small aneurysm. Here's one large aneurysm. Another one is a small aneurysm on the other side. This one is all tortuous. This is kind of straight, right? So two things are important about that. Number one is you can see that this is only the lumen that you see. Here, you can see the actual size of aneurysm. So CTAs allow you to see the calcifications, the actual size of the aneurysm, and a lot of other parameters that are very useful. So from a standpoint of quality, it obviously is better than an angiogram. But more importantly, look at the runoff here. Big, nice vessel. Look at the runoff here. Nada. So this is bad one. This is the one you send to your competition. Have them take care of that. And no popliteal aneurysm talk can be complete without mentioning that former vice president had popliteal aneurysm repaired with the endograft, the same procedure with the Vibond grafts. And so the joke goes, everybody needs a little gore in them, because this is made by the Gore device company. So, thank you. Hope you enjoyed it.